Hi, everyone. Good morning. Welcome to this webinar. My name is Sierra Clark, and I'm going to be giving a presentation today on behalf of the work that myself and collaborators have been doing over the past couple of years to quantify the burden of disease due to transportation noise pollution across England, so doing so at regional as well as local authority district levels. Um, I am a lecturer in population health within the Population Health Research Institute at St. George's University of London. My background is in environmental epidemiology specifically, and prior to this, I worked at the UK Health Security Agency within the noise and public health team, as well as then after that as well, the air quality and public health team. So also before I get started talking about the work that we've done, I also just want to highlight the many core team members who've been involved in this work. So we have Dr. Ben Fennick. He's a noise and public health team lead at the UK Health Security Agency. I've already introduced myself, so I'll skip over that one. And then we have Prof. John Gulliver. He's a professor at St. George's University as well of London, where I'm at, and he was previously at the University of Leicester. Prof. Anna Hansel, who's a professor at the University of Leicester, and then Dr. Calvin Jeffcoat, who is also at the University of Leicester. So before diving into the work that we did to quantify the burden of disease, I'm just sort of going to back up and talk a little bit about the health evidence that we have. I mean, I think for probably many people on this call and within this network, I mean, this information is probably nothing new to you. But just to make sure everyone's on the same page, the epidemiological evidence that we have on the adverse health impacts of exposure to noise, particularly from transportation sources, has been growing rapidly over the last couple of decades. And this has also been supported as well by mechanistic and experimental studies. And for example, just to go through some of these, exposure to noise, at night, for example, can impact sleep duration, patterns, and quality. There's also indirect impacts on cognitive and emotional responses and cognition and particularly child learning and development as well. And this is mediated through, for example, the disturbance of activities and people's communication, as well as their sleep as well. And then this can then have downstream impacts or lead to things like being annoyed to noid or highly annoyed to noid, and even downstream from there, possibly depression. And as well, thinking about the cardiometabolic side of things, also through both direct and indirect pathways, noise can also have a cardiometabolic impact on health. This is through chronic activation of the autonomic nervous and endocrine systems. And exposure, long-term exposure to, again, particularly studies of transportation noise, multiple long-term and large-scale studies over the years have showed an increased risk of incident ischemic heart disease, for example, stroke, as well as diabetes. In more recent studies, this is also linked to cause-specific mortality from those diseases. And in even more recent evidence as well, there's links to all-cause mortality as well from transportation noise exposures. So the majority of this evidence comes from studies conducted in Europe. And as I mentioned, we have the majority of evidence for transportation noise exposures. And within that as well, I mean, it depends based off of the health outcomes, but we have most of the evidence as well for road transport noise exposures. So given the current epidemiological evidence base that exists, it is possible to quantify what the burden of disease is that's due to noise exposure. And there have been burden of disease estimates made for Europe, for example, by the WHO in 2011. And more recently, this has been done by the European Environment Agency in their 2020 reports on environmental noise in Europe. I should also mention there is a new updated burden of disease quantification coming out by the European Environment Agency this year, but so far in terms of what's published, the most recent one is from this 2020 report, where these quantifications show a substantial burden of disease due to environmental noise, essentially culminating in over 1 million disability adjusted life years lost in Europe. And this was as a result, or this was attributable to noise exposures, transportation and also industrial noise exposures in 2017. So with these estimates then of burn disease, what we can do is we can compare them across other environmental or even non-environmental risk factors. So for example, the figure on the slide is from a recent review that I was involved in, and it shows essentially a comparison of disability-adjusted life years lost, or DALYs, and I'll talk a little bit more later in the presentation of what a DALY is. But essentially what this is doing is comparing a metric called DALYs, which is a measure of the burden of disease. DALYs lost within Europe across a whole range of different environmental risk factors. And some of these risk factors, such as ambient PM2.5 air pollution, are included in the Global Burden of Disease study, which is, a big worldwide study that does these comparisons. It's basically their bread and butter, but not everything is included in the Global Burden of Disease study. So this recent review, which was also done in collaboration with folks within the GBD study, was trying to bring some more of these environmental risk factors into the story, including environmental noise, to start making some of these comparisons to really see where they rank. And what we can see, at least from just this comparison, is the DALYs attributable to environmental noise in Europe. And this was based off of the European Environment Agency's estimates, which I just talked about. They are, lower than, for example, ambient PM2.5 air pollution. I mean, ambient PM2.5 air pollution always sort of dominates, but, and lower than occupational exposures and other things like the impacts of low temperatures. However, it's higher than, other exposures, which, people might not have thought that it actually would have been higher than, like, for example, ambient ozone and ambient NO2 air pollution. Environmental noise comes out higher than that. Residential radon, or even high temperatures, for example. So that I think these comparisons are quite useful. That said, this specific estimate for environmental noise, it should also be mentioned that this is still possibly an underestimate, because they're based on this estimate was based on previous environmental noise directive strategic mapping. So I think this was round 3. This essentially only captures some of the population, and it's limited to, for example, major sources and in agglomerations that meet a certain population size, threshold. And the reporting from these strategic noise maps is capped at 50 decibels for nighttime noise, L night, and 55 decibels for L den, day, evening, night. So you can already sort of imagine there, this is missing a big chunk of the population. So it's very likely that this is an underestimate. So why quantify the burden of disease from noise in the UK, for example? Well, environmental burden of disease assessments, they provide input into health and environmental decision-making and planning processes. They can be very useful for research and funding prioritization, and justifying that prioritization. And they support environmental management or regulatory efforts. And they're also very useful for making impacts visible. They are intended to be communicated and communicated and sort of displayed in ways that are accessible and are interpretable to a range of audiences. And so it really does and can help with engaging with the public and engaging with other policy folks on these matters. So it helps to make impacts visible. And then also another factor around this is often when the burden of disease due to environmental or other non-environmental risk factors are calculated, they're often done so and communicated using standardized metrics, such as the metric that I've mentioned before, the disability adjusted life years lost metric, which I will talk a bit more about in a coming slide. But these standardized metrics are useful because they then do allow for comparison across a whole range of environmental, social, behavioral, and dietary risk factors. And they allow you to also compare across geographies and health outcomes because they're all on the same scale. They're standardized. And up till now, I mean, I've been sort of showing, what I would call is like country or region specific estimates, and these are very useful. But what they don't show you are the local impacts on disease burdens, and this is really important for identifying and prioritizing local interventions and policy making. These exposures, and particularly noise exposures, they're not uniformly distributed across populations across the country. We know that some people are impacted more than others, and it's important to know, where and who, so that we can prioritize interventions and policies in those places to mitigate exposures and improve health and well-being. So that takes us to then the work that we did. So starting back with, I guess, just start from the beginning, which is that the UK Health Security Agency, which was at the time of this work starting Public Health England, basically externally commissioned a project to develop a toolkit to quantify the burden of disease across English local authority districts due to road, rail, and aircraft noise exposures. And this was a competitive tender that was won by Extrium and the University of Leicester. And the project to deliver this toolkit was completed in 2021. So just to give a bit of a sense of who's involved in the timescales. And before I get into some of the more specifics and the nuts and bolts of the data inputs, I'm just going to give a very sort of high level overview of the environmental burn disease quantification approach that we took. Also to say that, this isn't the only way that this can necessarily be done. The way that we approach this is a very common way. It's, sort of the process and procedures that are, been used by, for example, the World Health Organization and the Global Burn Disease Study. However, it's not the only way. So just to say, there are some other approaches that, folks take. I have seen, for example, in more the chemicals field using toxicological evidence as opposed to epidemiological evidence. So just to say, it's not the only way. However, the approach that we took essentially has these kind of key components to them. And I am going to sort of simplify it a bit, but just to give a high level overview is that first, we basically start off with trying to identify population exposures. So in the case of noise, this would be, what percentage of the population is exposed to different increment levels of, noise for a given source. And because for our work, we were working at the local authority district level, we had to do this within each local authority district. Population exposures are then combined with epidemiological exposure response relationships for the specific health outcomes for which there is, robust evidence that there actually is believed to be a causal link between those exposures and that health outcome occurring. You wouldn't just do this with any sort of health outcome out there or just a publication of one paper. This really has to be looking across the whole evidence base and determining that there is strong enough evidence to say, yes, we're going to make quantifications for these health outcomes. So when that has been determined, then taking sort of the best evidence exposure response relationship. So that could be in the form of, relative risk ratios or maybe other epidemiological measures of effects such as odds ratios or hazard ratios, but taking those and applying that to the population exposure data. I should also say, though, that there's other pieces of information that comes into play here, such as the shape of the exposure response relationship. Not everything is a linear relationship or increase. So the shape of the relationship comes into effect or into account, as well as whether there's any thresholds of effect. So a threshold of effect would be, a point along the exposure distribution line at which we might think below that level, we actually don't have evidence to show adverse impacts on population health, but above that level, we do start to see an increase. So that would maybe be a threshold. So that information comes together and is combined to estimate what we call population attributable fraction. This is essentially defined as the proportion of the incident cases of disease which are attributable to the distribution of the exposure within the population. And, one of the very useful things about that proportional, I guess, value is that if you then combine that with an estimate of what the total underlying incidence of that disease is in the population, irrespective of exposure, or we could be working with mortality cases here. If you combine those two things together, you then get an estimate of what the attributable number of new cases of disease are in the population as a result of that exposure. So it's, these estimates, they can be fairly simplified in some sense, but they have a lot of underlying assumptions and decisions behind them, which make them up at every step of the way and making decisions about what's the strongest evidence or what we can actually quantify and what we can't. So next, once we have those, what I would call additional cases of disease or mortalities that are attributable to an exposure in a population, we can then go to the next step and calculate what the burden of that disease is using standardized metrics. So we make quantifications for disability adjusted life years lost, or DALYs. Again, this is a very commonly used metric of the burden of disease, but again, it's not the only one that that people use, or so it's but it is a very commonly used one, and it's commonly used because it combines both the morbidity and the mortality impacts of disease in society into one metric. So it takes both of that into account. And then it puts everything on the same scale, which is time. And that allows for comparisons across different diseases and geographies, et cetera. So for our work, we make quantifications at sort of 3 different geographical levels. So nationally, we then made quantifications regionally, and then also for 314 local authority districts. And then towards the end of the presentation, I'll also talk a little bit more about the work we did in London to look a bit more in depth into some of these relationships. So in order to make calculations, we had to use a wide range of data sources that, for the most part, were available at the geographical resolution that we were working at, which was our lowest geographical unit was the local authority district level. So, for example, just to go through some of this briefly, data on population distributions, mortalities, as well as life expectancies, came from the Office for National Statistics, or ONS. And then disease prevalence rates came from the Fingertips web service. This is run by the Office for Health Improvement and Disparities, or OHID. Essentially, we used indicators that were based off of quality outcomes framework reporting. Essentially, this is reporting by GPs. Trying to think what else. Our noise exposures, and for this work, were based off of strategic mapping done to fulfill the requirements of the Environmental Noise Directive Round 2. And so we, and basically our 2 key sort of noise metrics here were LDEN and LNIGHT. We also, based off of, sort of what was available from this data set, we only had exposures above 50 dB for both LNIGHT and LDEN. So that's something that I'll talk a bit more about afterwards in terms of, again, thinking about possible underestimation here, and thinking about, the whole group or the population that's not actually counted here in terms of burden of disease. But that's the noise exposure data we used. And then disability weights, which go into the morbidity component of the DALY, were sourced from the World Health Organization, as well as the Global Burden of Disease Study. And then our health outcomes that we used in the corresponding exposure response relationships were based on systematic evidence reviews that were conducted by this team. So based on those evidence reviews and essentially reviewing, the evidence in them and the strength and the certainty of the evidence, we made quantifications for the following health outcomes with regards to these 3 transportation noise sources. So, for example, burden of disease from being highly annoyed and highly sleep disturbed, we make quantifications for road traffic, railway noise, and aircraft noise exposures. Ischemic heart disease for road traffic and aircraft noise, and then stroke and diabetes just for road traffic noise. Um, and it's important to mention here that, by not quantifying, for example, IHD, stroke, and diabetes impacts from railway noise exposures, it shouldn't be interpreted from that or from this work that we're just saying that, those health outcomes are not linked at all to railway noise exposures, or that there's no burden of disease in relation to those outcomes from railway noise exposures. We just don't have good enough evidence at this moment to support that point. And we are taking a bit more of a conservative approach with this. So just to sort of clarify that there. And also, I guess to say is, even since we did this work, so when we were doing the quantifications, this was back in like 2021, early 2022. And even since then, the epidemiological evidence base has since even, really transformed for some health outcomes. So, if we were to do this work today, it might look a bit different. And then in terms of this table, I won't spend time going through all of it. It's just to highlight here, and this is included in the publication for this work, just to highlight all of the exposure response relationships that we used for each of the health outcomes and noise sources, the corresponding lower and upper threshold limits that we applied. This is also based off of reviewing the evidence, and then the disability weights as well. And part of also why we have all this is just because through this whole work, we were really prioritizing transparency and just making sure that every decision we made was very clearly laid out. Every input that we used was very clearly sourced and laid out, just so people are aware, because what you decide to include in terms of inputs or different assumptions that you make can really impact these results at times. And that's been shown in other studies. So it's just, we really prioritize being transparent. So also just to say that this table highlights the primary exposure response relationships that we used in the analysis. However, we did also conduct a series of sensitivity analyses. So for example, we estimated the burden of disease or DALYs using alternative disability weights where some were, available, and there was, reasonable evidence to assume that these alternative ones could also be applied. So we use alternative disability weights. We also estimated disease burdens using alternative exposure response relationships for IHD, stroke, diabetes, and being highly annoyed. These are from studies that, for example, might have been published as conference papers or from maybe a single but very large scale like cohort study. So this is where we didn't feel like the evidence was as strong for these, but maybe they were more recent than the ones that we use. So we also want to see what happens to the burden of disease when we apply these other exposure response relationships. And then finally, we also estimate the burden of disease with an alternative, what we call more complete road traffic noise model for London. And I'll talk about that now. More complete meaning this alternative noise model, which was based off of running it through using the Knaus framework. This was based off of modeling road traffic noise exposures for all roads in London. So not just limiting it to sort of the major ones. This is for all roads and had exposure ranges which went down much lower. So as I mentioned before, for our main estimates, we were using the noise maps developed to fulfill the N2 strategic noise mapping round. But that had a lower threshold cutoff at 50 dB, L night and L den. This alternative one that we had for London, which was developed by colleagues in part of this work, John Gulliver, for example, specifically, this had a lower threshold that went down to 35 dB L night and 40 dB L den. And so you can see even here, just with this figure on the y-axis, this is showing the number of adults exposed in London in the thousands. You can just see how the distribution is already quite different when you have that larger exposure range, but also when you include, all roads. So we want to explore whether within London, because that's where we had this data for, what was the degree of possible underestimation in our primary quantifications when we introduced this new model in. So I'm going to go into the results now. And just to say that the results that I'll be presenting come from these two publications. One was sort of our main paper published in Environment International, and this covered all of England. And then the other one was looking a bit more in depth in London. Sorry, just one second. And yeah, and this other one where we looked more in depth in London was published as a conference paper. So to start off, just looking at, the exposure maps. So this isn't including any health quantification at the moment, just the exposure maps. What we can see and what they're showing is the percentage of the population exposed to railway, road traffic, and aircraft noise above 50 dBA LDEN. So that's just showing within each local authority what percentage of the population is exposed above 50 dB LDEN. And what you can see is there's quite a lot of spatial variability. It's quite visible for road traffic noise as well as aircraft noise exposures. For railway, I know it doesn't necessarily appear that way visually, but that's just because of the scales that are used on the map. And because across local authority districts, there's actually only a range of between 0 to 20% of the population exposed above this level to railway noise pollution. But because of the scales on the map going from 0 to 100, it just looks like there's not a lot of variability, but there is. And then in terms of how this translates to health, the figure on the left is showing the regional distribution of DALYs, disability adjusted life years lost, for each of our 3 transport sources. And the table here is just showing, sort of the national picture and numbers for road traffic noise. And so across all noise sources and health outcomes, we found just slightly over 100,000 disability adjusted life years lost per year. And the most recent year of analysis was 2018, based off of when we were doing this work back in 2001. 2018 was the year we had the most recent updated data. So we found just over 100,000 DALYs lost in 2018 for the adult population in England. And I should also say for all of these quantifications, we restricted it to adults. Looking at this figure here of looking at the regional distribution, you can see that road traffic noise exposures accounted for the majority of that burden of disease. You can just see that the bars on the bar chart, they're much higher than for the other 2 sources. However, you can see here for aircraft noise exposures, the bar for London really sticks out. So there's quite a lot of contribution there from aircraft noise. And then also across health outcomes, we also found that being highly annoyed and highly sleep disturbed accounted for the majority of the DALYs. So now looking at the maps and the variation across the local authority districts, you can just see visually from the maps just quite a high degree of variability, which is, what we would expect for an exposure like noise. We see higher levels in the Northwest, in the Midlands. You can see it quite clearly when we're looking at the maps for being highly annoyed and highly sleep disturbed. So Northwest, the Midlands, as well as in and around the London area, sort of where we see those biggest clusters. And I should also mention with these maps, these are showing the DALY rates per 100,000 people, or per 100,000 adults, I should say. So this takes the population size within each local authority district into account. So stripping away the influence of population, this is, the map that we see in terms of the clustering of where the highest sort of DALYs are, impacts are. And then in terms of railway noise exposures, it's a bit harder to sort of pick out trends. It's a bit more sort of disjointed, but generally we see sort of the clustering as well in and around London, and then some of the local authority districts with some of the highest DALY rates really are just following the major rail network north to south in the country. And then in terms of aircraft noise DALYs, again, I mean, it's very much clustered around the airports, which is what we would expect. But I think what's really interesting to pick out here is just when you look at the inset map for London, you just see how sort of much of a contribution there is from, Heathrow Airport, for example. I mean, it's just the local authority districts there around Heathrow just have much higher DALY rates than sort of any other area. And so now this is showing the results from when we did the sensitivity analysis comparing the DALYs in London from road traffic noise exposures when we used our main exposure data set. So this is from the end-to mapping where we had a restricted range above 50 dB for LDEN and L-night and compared it to our alternative one where we had all roads included and a much wider range. And so when we compared the DALYs within London between these two exposure models, what we found was that there was around, it differed by health outcome, but there was between about 1.09 to about 2.5 times more DALYs lost with the alternative exposure distribution for road traffic noise compared to our primary ones. So that is indicating that we are possibly underestimating the road traffic noise burn disease, at least within London. And that's, the area that we were able to analyze this. So then, given those differences, what we did is we wanted to look a bit more in depth within the London region using this alternative road traffic noise exposure model to look at how does that translate to a burn disease within London, but also to see if whether we wanted to also do some exploratory work to see whether those the spatial patterning of the burn disease from road traffic noise in London had any sort of relation to measures of neighborhood socioeconomic disparities, for example. So within London, I mean, this is just showing, again, sort of mapped out in the map of London. You can see all the different boroughs here. I think there was 33. And you can see what's basically showing is a histogram for each borough of the percentage of the population exposed to different levels. In this case, I'm just showing the LDEN road traffic noise levels here. And then the yellow coloring is indicating the part of the histogram. So basically the proportion of the population within that borough that is exposed to LDEN noise from road traffic below the WHO guideline, and then the purple is indicating above. And basically what we can see is we want to look at first just how much variation there was between boroughs. And what we found is there's actually quite large differences between boroughs in terms of the percentage of the population that was exposed above certain thresholds. So for LDEN road traffic noise exposures, we found on the lower end that one borough had 27% of their population exposed to road traffic noise above the World Health Organization guideline. And on the upper end, another borough had 72% of their population exposed above the World Health Organization guideline for road traffic noise for the LDEN indicator, day, evening, night. And then for nighttime noise for L-night, this ranged between 40% to 82%. So you see quite a lot of variation across London boroughs in terms of exposures. And then this also translated then to the spatial distribution of the estimated DALYs or health impacts as well. So what you can see from the maps on the top sort of two panels here, this is for being highly annoyed and highly sleep disturbed. You can see that central London had the highest attributable DALY rates from annoyance, being highly annoyed and highly sleep disturbed. And then the spatial patterning for the other three health outcomes, ischemic heart disease, stroke, and diabetes, it was a bit less predictable, but that was because with these three health outcomes, we're also introducing in the underlying disease and prevalence rates and downstream mortality rates as well. So those underlying rates also play into the spatial patterning of these impacts. And because those are not always the same across boroughs, we see slightly different patterns. But we do still see for stroke, for example, still some clustering in central London as well, and somewhat similarly for ischemic heart disease, but it's not as clear for the other ones. And then finally, we wanted to explore whether the spatial patterning of noise attributable DALYs in London was correlated with borough level deprivation indicators, and specifically indicators of income deprivation, as well as the index of multiple deprivation, or IMD. And really, I should stress this was a very exploratory work. And we just wanted to see if there was any sort of signals coming up. And what we did notice, and I'll try and highlight it here with these boxes, is that we did find a relatively consistent positive correlation between road traffic noise DALYs and the proportion, or this indicator called the proportion most income deprived within boroughs. This is essentially represents the proportion of LSOAs, which are a smaller geographical unit in the borough. So it's the proportion of LSOAs within each borough that fall within the 10% most income deprived nationally. We also found moderate positive, though not always statistically significant, correlations between the road traffic noise DALYs and a measure called the deprivation income gap. And this kind of largely reflects how wide or large income inequalities are within the borough. So this is more of an indicator of inequality within a borough. But then also what we found is when we looked at the road traffic noise DALYs that were specifically due to or linked to diabetes as being the health outcome, we also found some relatively sort of consistent positive correlations with the majority of the neighborhood deprivation measures. So again, just showing that, but being very clear that this is very exploratory. It's just kind of some food for thought to see, are there some signals here? But really, ideally in the future, we wouldn't want to be looking at these relationships at the borough level, which is quite a large, sort of geographical scale for this. In the future, we would want to be looking at much smaller scales. So, for example, LSOAs, lower layer super output areas, or MSOAs. So, this was just to see, do we see any signals? But in the future, we'd want to look much smaller geographically at this. And then just some sort of concluding remarks. I think I just have this slide and one more then to finish up. So just some concluding overarching remarks on this. This work represents the first small-scale geographical assessment of the Burm disease due to noise in England. I'm fairly certain that this is the first one, throughout the UK, but at least, we just did this work for England for now. So, it does represent the first assessment looking at these relationships at small geographical scales, small, in this case, meaning local authority district levels. And while we found a substantial health burden attributable to transportation noise across the local authority districts, there's also quite a lot of variation between these local areas as well. And, sort of across the board, road traffic noise contributed to the majority of the burden of disease across these three transportation noise sources. But again, part of that, or part of what's partly influencing that as well, comes down to the evidence that we have, the epidemiological evidence we have of these exposure response relationships, and then how much health outcomes we can include in these quantifications. So that comes into play, for example, in what ends up coming out as the noise source with the biggest impact. And then when we compare these disability-adjusted life years lost within England from road, rail, and aircraft sources combined, when we compare the total DALYs to, for example, what had been estimated for ambient PM2.5 air pollution in England, comparing it to the same population group, so adults, and over the same time period in 2018, we found that, still very unsurprisingly, ambient PM2.5 air pollution came out higher as having a higher contribution to the Burm disease within England. However, our transportation noise DALYs were higher than, for example, occupational noise, ambient ozone air pollution, residential radon, as well as one of the climate sort of indicators, so high temperatures. And this is all based off of making comparisons to global burn disease data sets. And then also, as I mentioned as well, it is possible that we're underestimating, at least with our main estimates. So it is possible that we're underestimating the noise burdens, through our use of the end round 2 exposure data. And just obviously to know, it'll be interesting to see how things change now with the new round 4 noise data, which is sort of much more comprehensive and has lower exposure thresholds. So it will be interesting to see how things might change. I mean, as I mentioned, this work was done sort of actually now a few years ago. So, things have really changed even since we did this. And then in London, road traffic noise attributable health burdens as well. As I mentioned, they were, in some cases positively associated with the spatial distribution of some measures of income deprivation at the borough level. However, this is very exploratory, and we will need to look at this at much smaller geographical resolutions in the future. And then just my last slide is just to kind of highlight some of how this work has been used since it's been published. So the key results from this work were highlighted during the House of Lords inquiry on noise and light pollution, and the estimates were included in the final report. So you can see that here. And then also the work was recognized by the Noise Abatement Society this year, winning the John Connell Award for Innovation. So yeah, we were very sort of pleased to receive that. And yeah, that is all. Thank you very much. Feel free to get in touch if you have, any other questions. I mean, I'm happy to take questions now, but also feel free to get in touch later if you want. Here's my email.